Hi, thank you for having me. My name is Jonathon. My job is radiation therapy. I'm a radiation therapist in Prince Edward's Hospital. So, Prince Edward's Hospital is located in Randwick, right next to Coogee Beach and right next to Randwick Racecourse. So, during the Melbourne Cup days, you get very happy. So, we recently built a new cancer center. There's a picture of it, trying to just show off a little bit. So I'm going to talk about external eye fixation. So background of it, we treat choroidal melanomas, which accounts for 85% to 90% of the uveitic melanomas. But it's a very rare disease, only found by 6 to 7 cases per million people. The standard treatment for this disease is usually removing the complete orbit. But once again, there's worst case scenario for the patient. We might cure the disease, but it's not the best experience for the patient. So we have a different option for the treating this condition, which is called radiotherapy. Now, same as other melanomas, is known for very aggressive growth. So we have two different approaches for radiotherapy. One is brachytherapy, and one is external radiotherapy. For brachytherapy, you can see in the picture, we put a little plate of radiation source behind the patient's eyes, and usually about 7 to 14 days, patient goes home, have a normal life, and then comes back and take the plate out. But in some cases, where the disease is near the optic nerve, it's very hard to place the plate behind the optic nerve. So we have to have some kind of different approach, and that is external radiotherapy. So, external radiation therapy, for this particular technique, there's a name for these two different approaches. One is called fractionated stereotactic radiation therapy. Another one is called stereotactic radiation surgery. This technique delivers very high dose to very small target. Why we call it stereotactic radiation surgery? Sometimes we have one treatment, and because we have one treatment, we call it as a surgery. And that's why it's called stereotactic radiosurgery. In some cases, depending on the diagnosis and the geometry of the target we want to treat, sometimes the patient comes multiple times, and that is called fractionated radiation therapy. So what kind of disease areas we treat in this area? Well, trigeminal neuralgia, vestibular serenoma, AVM, pituitary, so it's not really limited to cancer as well. Okay, so this is a sample of the plan, radiation plan. So you can see the red area is a very high dose, and we're trying to put a lot of dose into one central area, approaching from different direction. Because we're treating a very small target, we have to have a really high accuracy. So two main methods of delivering stereotactic radiotherapy or surgery is one called gamma knife. We have a does that laser pointer work? No? Okay. There's a patient going to this dome, have a radiation source implant to it, and then they open the little gates and they expose a bit of radiation. Another method is called linear accelerator-based radiotherapy. We have a particle accelerator, and the patient is lying in the middle of the room, and the machine goes around, and we deliver a very strong dose to the patient's head. So, what's the problem with the current system? Because high level of accuracy is required, and the eye is a moving organ, and because we're treating a very small target, if the eyeball moves around a little bit, we completely miss the area of interest. So, in this particular case, for treating melanoma, we're not having a one fraction, we're treating with 5 fractions. So we have to come up with the plan that patient can be reproduced the position every day and have an eye position fixed at the same spot. So the patient outcome is important. However, also patient comfort is also a very big factor for us too. Quickly going through the process of the radiotherapy, the patient comes to CT simulation, which is taking a CT scan of the patient's head, and the patient is going to MRI. So there's two images fused together, and we create the treatment plan, and we give the treatment afterwards. So the idea came through as the patient lying on the bed with the little camera at the front, and the camera is projecting the image to the laptop, and we trace the shape of the eye in the laptop, and we can monitor the patient through that. This is actually a picture of the patient with the stabilization method and the camera at the front of the eye. Now you can tell the camera is not very expensive. It's like $20 from Dick Smith. So it was very cost effective. So because we can't take the metallic parts into the MR scanner, we do something called partial fusion. Instead of fusing the whole complete head, we fuse according to the orbit location with the lens and the optic nerves and the targeting area. You can probably notice on the left, at bottom left corner, with the transverse slices, there's two outlines. So inner outline is called CTV, it's called clinical target volume. That's where disease is. And outer outline is called PTV, it's a planning target volume. So we give a tiny bit of margin, so we can allow a slight error. So we come up with the radiation therapy plan. This is example of different plans we can do. And to the radiation oncologist, we usually give it 3 or 4 different plans, and they can choose one. If you look at the top right corner, we can see target and GTV chart. You can see that the part we want to treat is getting quite a high dose, but lens is getting very, very small dose. And this is one of the examples of the beam, or how the shape of the radiation is trying to irradiate at the target. 2 years ago, we did 9 patients, and we did a 6-month follow-up. It was quite successful. 100% of the patients either showed regression or control. So we thought, okay, this is going right direction. Let's keep doing this and make some improvements from there. So what's happening today? We did about 24 patients so far, but about 22 patients had review. Unfortunately, one patient had a very slow response, had to take the one eye taken out, but we're very happy with 95.5% success rate. So we're thinking, okay, let's try to make to 98% or 99%. So challenge is once again, we can't take the MRI, we can't take the equipment to the MRI machines. Planning this treatment itself is very difficult because of the very small target, and because we're having a camera in front of their eyes, the patient is very difficult to maintain the position. And this particular patient, because he had a cancer in his left eye, he had no vision in his left eye. So we have to have a separate light source using the right eye, looking at the light. Then we have found some stable position from that. But are we the only ones doing this? No. There's some centers in Europe that are doing this, and some American people doing this, and in Melbourne, they have started doing this as well. How are we gonna? So the project comes down to this: how are we gonna track the eye? Can we still use $20 Dick Smith camera? No, we can't. So we've been digging some different journals and what's happening around the world. And some people have in the world, they have come up with the machine that you can actually track the position of the eye. And this is the budget version. You can actually make it at home for $50. But we thought, okay, we don't want to do this. But some of the centers in Europe have come up with something similar to what we did, and they were doing this for about 10 years. So they had the same system, had a camera in front of their eyes, and they actually measured with the little rulers next to them. In Japan, they were very good with small, delicate things. What they did was they made a thermoplastic mask, and they attached a little mirror to it, and at the end of the treatment couch, they had a high-powered digital camera. They zoomed it in, and they projected the image to the computer, and they had monitored that way. And they had also treated about 13 patients, but they had one failure, so we're still better than them. So what's happening to a lot of centers as well? So all of the centers in Europe, they start looking into this, and they have quite good results, good papers coming out. So what is future for Prince Albert's Hospital? And with regard to this technique, it has to be cost-effective. You still have to give a same accuracy. You have to be reproducible, and you have to have a good patient experience. So we've been doing some market research. We have found this a company in America that supplied this eye tracking system that used for tracking the eye movement of the jet fighter pilot, so they can tell where the enemy planes are. Unfortunately, the rep from this company was in Australia, so we had a quick chat with my boss, and then I asked them, okay, let's get the basic question, how much was it? He said $100,000 US. Okay, I nearly flipped the chair. Okay, thank you very much. Have a nice coffee and talk to you next time. And we found this company, they also tracking the eye position for the marketing research. So when you have a poster up, where the man is looking at and the woman's looking at, with the shampoo ad is on, where they're looking at. So anyway, the cost of this was $1,400, and it was still quite dear compared to $20 Dixmate camera. Then we found this, which is a game advice. We plug it into any iPhone, and then it actually traces your eye movement to play the games, and it was $199. So we're getting close. And then we found these people in the YouTube. If you have kids, you probably know they have a facing swapping software, right? So these guys who developed those things, and they were happy to give it to us for $20. Something okay. Now, and then I found this software for free. It actually can track my eyeballs. So I sat down with my boss and said, look, what can we do with this? And my boss and the director of the physics and all that said, look, we can't rely on this treatment with some high school kids running a software. So we have to actually spend money on it. So, okay, that's fine enough. So we got the okay to buy $5,000 camera, 12 of them, ultra high definition Samsung security camera. So we worked out the cost of what's going to happen in the future to develop a new system for us. We have to build a new system, mounting system, about $200. Patient stabilization equipment is about $300. Software development to monitor the patient's eye. We don't know how much it's going to cost, and number of coffees, we don't know. So we come down to developing the software development. We found that if you can ask junior physicists to do this, they can work really hard for it. So this is software that we're trying to build. This is not our software. I downloaded from the Google. So what the software does is it detects the color. And whenever there's a movement of these color changes, it tells you exactly where the location is. This way, in the future, hopefully, we're trying to develop automated or gated machine turn on and turn off systems. So if the patient eye is a certain distance away from the origin center, you can shut down the machine. This is the thing we're trying to develop on. So the things we have to also careful with when you're developing these things is dose coverage, technique, what kind of techniques can we still use, the current treatment delivery technique to these cases. Can we still use five fractions? All these kind of questions come to us, which will give us definitely a fantastic research opportunity for this. So for us to think about it, our future for us, the homework for us is to build a camera, develop software, and make sure we have to review the patient every single 6 months or 3 months to make sure this is working, and make sure the patient is comfortable. Thank you very much. Yeah.